Good afternoon, everyone, and welcome to this exciting workshop entitled Cultural Competence Transforming Understanding into Impact, organized by Work Package 4 of the CORE project. We are happy to have you join us today. Before we dive in, let me briefly introduce the CORE project. So CORE stands for Community Responsive to End Inequalities. It's a 36-month initiative that starts in January 2023, involving 24 partners from 16 EU member states. So the project aims to reduce inequalities in the HIV, TB, and viral hepatitis responses by promoting, strengthening, and integrating the community responses. So my name is Hala, and I'm a project officer at Africa Advocacy Foundation in the UK, one of the partners in the CORE project. It's an absolute pleasure to facilitate today's session and have all of you here. We are also joined by an incredible trainer, Juddy Otti. So Juddy brings over 15 years of experience in the HIV sector, working on initiatives ranging from HIV prevention programs to advocacy and personal development for people living with HIV. Juddy is passionate about uplifting migrant Black communities and ensuring their voices are heard in national strategy and policy conversations. So she's an inspiring advocate, and we are fortunate to have her with us today. So welcome, Juddy.
Thank you.
Before we start, just a few quick reminders. This session is being recorded for sharing on our website, but don't worry, the final video will focus on Judy's input, so please feel free to speak openly. We are welcome to participate by using the chat or raise hand feature if you want to share your thoughts during the conversations. The workshop will last 90 to 120 minutes, and at the end, we will have a short 5-minute evaluation to hear your feedback. And now let's get started, and over to you, Juddy.
Thank you, Hala, and good afternoon, everybody. I believe it's afternoon for everyone. Well, if it's not, good day to you. And thank you for that introduction. And I am really pleased to be here. What I'll do is I'll share my slides now. So what we're looking at today is the importance of culture competence and how this can apply to the different roles you play in the different organizations and communities that you support. That's my email and LinkedIn contact that I will share again at the end. And I know that Hala has spoken a little bit about little housekeeping, but I also thought I'd bring in a little bit more around agreement for today. For us to focus on confidentiality, and that means if anybody shares particular stories, let's take the lesson out of that and not the content. Respect everyone's or each other's opinion. Let's disagree constructively. Listen to each other. Let's avoid homophobic, sexist, transphobic language or anything that can be offensive. But above all, let's all take part and get involved, and feel free to ask questions. I have a bit at the end for questions, but if you have questions in between, please feel free. I'm aiming for this to be as interactive as possible, so there'll be opportunities for us to discuss in groups. Hopefully we will have breakout rooms where we can discuss, and use the chat as well, and raise your hand with the normal Zoom functions or physical raising the hand. And if I can't see you, I'm relying on Hala to help me. Just notify me that somebody's got their hand up. So the objectives for today's training is to get a definition for what cultural and linguistic factors are, how they shape our identity, stereotypes, bias, and cultural awareness. We'll also be looking at cultural identity and evaluate how this shapes our own biases that we come with. We'll develop a personal awareness for these topics and how they relate to the roles we play in our different organizations. And lastly, the role of culture competence in reducing health disparities, especially in migrant communities. And I'm hoping that I'll cover all of this. And there is a lot to cover, but I'm really optimistic that we will get through it. So I thought I'd start with an icebreaker, and that will give me also an opportunity for me to get to meet you and know who you are. So I'm going to ask, and we're going to do this. So I'm going to give you 3 minutes to do this, and then the 7 minutes to just feedback. So that way, that's us getting to know each other. So and hoping you have a piece of paper. If you don't, on your phone, on the laptop, I would like you to write your name in the center of this piece of paper, in the middle. And around that, I would like you to answer the question, who am I? And this, I would like you to look at things like race, age, gender, identity, ethnicity, education, spirituality, career, anything you want. What do you really feel that helps? What do you feel identifies you? Thank you very much. And I'm hoping that, one, we've got to know each other, but also if you look at the scope and intersectionalities, and everybody's different, but there are similarities with some people in terms of religion, in terms of gender identity, in terms of sexuality, in terms of race, but there are also huge differences as well. And that's just how we find ourselves. So if we look at how this plays a role, again, as in terms of how we identify ourselves, how does that play a role in the culture and identity and intersectionality? And I'm going to read out these statements as definitions for what culture is, and I just want you to reflect. And if you can just either use the chat or put your hand up if you want to give your views. So culture determines how we see the world. In our worldview, it's the way we make meaning to things. We don't see things as they are. We see things, and I'm trying to move stuff around my screen, so bear with me. We see things, we see them as we are. So that, in a sense, is one of the definitions. And then the second definition is, again, let me move things around. The body of learned beliefs, traditions, principles, guides for behavior that are commonly shared among members of a particular group. Culture serves as a roadmap for both perceiving and interacting with the world. Can I have some of you tell me, what do you think about these statements? Do you agree? Do they resonate? Do you disagree? Do you have another idea? Yes, Faraz?
Yes, maybe just one observation that the first statement, that we don't see things as they are, we see them as we are, that's kind of more individual from my reading than the second one, which puts you in a community, regardless of whether you identify it as a neighborhood or nation whatsoever, or a community perspective. But the first one can be much more individual in my understanding, because we are all different, so we see things differently as we are all different.
Thank you. And that's very, very helpful. And I agree. Any other observations or comments?
That's a comment too, that you become more aware of what so-called culture when you are outside of your comfort zone. Then you become reflecting on that. That's my experience. Just a comment. What we call culture, you become more aware of it when you move or when you are not where you are.
No, that's also another very good observation. We have a saying that you think your mother's cooking is the best until you leave home and try somebody else's. So it's that same analogy that you're using. But yes, it's sometimes it's subject to our perceptions, but there's a bigger, wider perspective as well that's formed by common shared behaviors, principles, and guides in different communities. So thank you for that. And then we also look at ethnicity. That also plays a role and what that is. And this is, sorry, I need to sometimes move you from my screen. So the ethnicity, and this is really referring to social groups, particular social groups in complex societies, groups differentiated not only by the basis of a range of shared culture content, but also on the basis of social attitudes, economic and political considerations. So I know you, as people working in the community, you're working with particular ethnicities of people. So I didn't want to dwell a lot on this. This is something I know you're very familiar, but for setting the scene for our training, I thought we also cover that. And then intersectionality, looking at how all these play a role, and some of this came up when you gave your identities and how you saw yourself. So it's a term that refers to multiple social identities that we have. It helps explain these intersectionalities and reflecting on the interlocking systems, whether it's around privilege or oppression that people experience at societal level. So can you name some of the intersectionality or identities or characteristics that you can think of? And some of these we've already talked about, but put them either in the chat or put your hand up. Just name some. Look around the room today, and some of the answers are among us. So just give me a few.
Sorry,
Yes,
this is Samash.
Yeah.
So I would start by gender.
Yeah.
Which I think is like fundamental. Even if you look at the emergence of intersectional thinking or theory, being a person of color and your gender are key axes of originally oppression. But of course, I like that you also mentioned the dimension of privileges, because it's a mix of oppressions and privileges, always. In case of everyone, I think there's a balance of these factors. So gender, race, age.
Yeah. As
an aging male, I increasingly, an aging gay male, I increasingly feel that that's also can be an issue. So these ones pop to mind at first glance, but others certainly have also other things to highlight or to mention.
Thank you so much, Thomas. And you've started us off, so yes. Any additional contributions verbally or in the chat? So, Thomas has shared identity, sexuality, gender, class. There is income, there is color, there is race, there's religion, there's language, there's occupation, nationality, education. All of these are the different intersectionalities in identity. So I'm going to put you into two groups. Chris, were we able to get the groups? The breakout rooms?
Yeah, I think Hala is going for it.
Okay. Hala, you can put them, I'll leave you to even do the group, the allocating of the rooms, but I'm going to put you in two groups, and I'm going to give you, because we're a large number, I'm going to give you 4 minutes to discuss why culture is important to us. Then we will have you choose somebody to feedback to the rest of the group, and then we'll have 3 minutes each from each group to give a feedback in terms of what you think culture is, and we will compare and see what if anything we feel we've missed. Hala, how are the rooms doing? Okay. I know that was very little time. I hope you are able to get something. So if we start with Hala, you call them what? Seller 1, Seller 2?
Because I have a friend, have French, so Sal 1 and Sal 2. Yeah, Sal
Okay.
1, Sal 2.
Okay, so Sal 1, can you please give us your feedback? You're muted.
Apologies. So in the very few time we had, we talked about the different the language system within specific countries that some people might not be able to provide necessary information or understand necessary information for healthcare, as well as specific community languages that communities specifically use, even if it's within the same language, some different vocabulary, etc. in that sense. Some belief systems have some rules that people follow that don't allow or don't allow specific maybe not to be touched by another person, or a man cannot visit a female doctor, or there is distrust in traditional medication, or there is alternative medicine involved in that culture. And contextually, when it comes to other cultures in the medical systems, or of other cultures that are more dominant in that sense, in that context, there could be stigma, there could be discrimination, there could be racism, and of course, the last point was there should be sensitivity in approaching differences in culture.
Thank you so much. And that was very, very comprehensive. So, Seller 2, what do you have to add to that hasn't been mentioned?
I think Uwe said something really useful and interesting. So I would invite him to repeat.
Okay. So I try to do it very shorter than the short time we had. I said the importance of culture in healthcare has two views. The one is what a healthcare system within a cultural framework is able to offer, how it is set up. And the other thing is the cultural aspect of the individual which joins a healthcare system and needs maybe support from a healthcare system. What they have, that the healthcare system is according to their cultural needs and thoughts and regulation. These are the two aspects. And my example was, for example, abortion, that there's healthcare systems which do not allow abortion under no circumstances. And there's healthcare systems which do allow abortion, sometimes under different settings, sometimes generally. And this is often based on a cultural base. A healthcare system is framed in. Yes.
No, thank you. And I think that's very key, because at the bottom line, or the end goal is for the healthcare system to serve that community. But if it is designed without that sensitivity in mind, then obviously you are going to have disengagement. Another good example was during COVID, where at the beginning, the introduction of the vaccine, a lot of sensitization had to go out because there was a lot of fear that the vaccine was made out of products that were not halal. and certain communities felt they cannot take those. There were considerations around what happens if I am fasting and I have to then take the vaccine. Does that mean I've broken my fast? So it's really understanding all these little things to the end goal is to engage in the healthcare system or healthcare service, but you have to factor in all these different things. So thank you for that. So these are some of the things that you have discussed. Oops, sorry. So, we've looked at the race, the ethnicity, the gender, the religion, all those play a role. Then you also have, I think something that maybe hasn't come up is the historical, the history of the culture or the impact to the history that and how that might be carried through trauma or anxiety and how that kind of plays a role. Things around their status and I think this for Europe is very, very poignant. I mean, in America, I think it's even becoming more poignant. Sexual orientation, and then you've talked about the language and dialects, which is also very key as well to consider. So thank you very, very much. So we know that culture forces are very powerful determinants of health-related behavior. I know one of you spoke about maybe not being seen by a physician of the opposite sex or being touched by a physician of the opposite sex, lack of knowledge about or sensitivity of health beliefs and practices of different cultures. There's also in certain cultures where you cannot look at somebody in the eye, others you can look at somebody in the eye, and how is that body language interpreted, and there is others where talking about sex is very behind closed doors, not openly discussed. Therefore, when you ask questions, the answers you get may be what they think you want to hear as opposed to what actually is the situation. So when we look at what shapes culture, sorry, was that somebody putting their hand up? Okay.
No, no.
When we look at what shapes culture, there are various things that shape culture. We know that political values, and again, I'll go back to the US, which is shaping a lot of that now with the way the policies they're going with now, experiences of oppression or discrimination. In some of the cases in Europe with the migrants, it's that they're migrating from areas of economic turmoil. What that experience has brought. In the UK, we have migrants who come on the boats, and that whole experience of making the choice that the best option you have is travel by boat when you know the chances of survival are one in, it's half. Those also really shape the resilience and how people perceive or how people engage. The socioeconomic factors, rituals that people have, and these are really in terms of whether it's around in certain cultures around cleansing. When we look at people, particular faiths, their particular rituals that they perform and what that shapes or plays. There's the family roles and structures, and in some cases where you have polygamy, which is accepted, other cultures where you have monogamy, which is accepted, and how all those shape decisions and interactions. And then there is also the degree of opposition or acculation. There is also the response to majority culture. All these really shape. Culture can also transcend. You can leave your country of origin with one culture, come into a different country and form a new culture that's blended with some of your own culture and some of the new culture. So it also transcends, and you have to be aware that that can also be fluid in a way. So I had put a 5-minute break, but I need to just check in if people are happy. Do they want a break? Are they happy to go on?
I think we're good to go on, honestly.
Good. So we're now moving into culture competence. And I want to hear from you, what do you think culture competence actually refers to? And yes, again, this time I want to hear some voices, or put something in the chat if you can't speak. What is culture competence?
May I say?
Yes,
To start, to icebreaker. I think
Please.
it is, I mean, in my mind, it is to be able to put ourselves in the shoes of the person we have in front of us, and in the relation we develop with her or him, with them, to understand, to learn and to understand who they are, who they really are, what are they, their beliefs and their, all the things that we have talked about now, all these differences and intersectionalities, and be able to adapt our language and our, way of relating to their culture, to their way of being, so that we can be understood and we can develop a relationship, a real relationship, and move forward together. This is, for me, is cultural competence.
No,
Put
thank
myself
you.
in the shoes of the other
Of
person.
the other person. That's a good way of putting it. Yes. Thank you very much. Ovi?
I will just say first that the understanding, the cultural competence is to, first of all, acknowledge that we have varieties of culture, and not to be expecting or framing and have too much expectation, like the person I'm meeting has this or that. We should be expecting a variety.
So again, it's similar bit to what Leila said about being sensitive and putting yourself, just be aware and of the differences and what that means. And I will underline the word means, because it's not just identifying them, but actually understanding how that affects how you engage with this person, how you communicate with this person, how you design services for this particular person. All of that, is it plays a role. So thank you very much. So one of the definitions is the state of being capable of functioning effectively in the context of cultural differences, which is a bit like what all of you have, both Leila and Pibble have mentioned. Then there is also a state of conjugate behavior, attitudes, and policies which come together in a system agency or among professionals to work effectively in cross-cultural situations. That's a bit wordy, but again, it's bringing in the different aspects around behaviors, attitudes, and bringing that all together within a system to make sure that you are providing a cross-cultural service. And cultural competence, how this plays a role in what we, how it influences the factors, social factors, or the reason why I think we are looking at this training is that these cultural factors really affect how people seek health services, whether they will seek them, whether they will think, okay, I have had a headache for 4 days. I think I'm going to continue praying about it, and I presume that the headache will go. Or I have sores on my genital area, and that means I'm being punished for something that I must have done wrong. So I must make sure I go and cleanse myself in whatever way they've been told. I know in Southern Africa at one point there was the notion that if you've been diagnosed with HIV, to get cured from HIV, you had to sleep with a virgin. So there are all those things. Instead of seeking professional help, culture does play a role in what people believe, what the rituals they perform, the way they look at healthcare services. And also what that leads to is then, sorry, I've moved before I move to that, but what that leads to is then seeking health seeking at points of crisis, as opposed to prevention, engaging in prevention, or before symptoms become critical. So it's understanding and those factors that play a role. Then there's perceived causes of illness. That's something I touched on, but it's in a lot of cultures, it's associated with how good you are, how prayerful you are, whether in many West African, Central African, I could be corrected, but I don't think this is a real issue in Europe, but it's around witchcraft and other people making sure you get ill because you've done bad or they don't wish you good. So even for certain people to come out and talk about whatever they may, to present whatever illnesses they may have, they would rather keep quiet because they feel if the community gets to know that they have these conditions, they will all know that they did wrong and that's why they are being punished, or that's why someone is sending these illnesses to them. So it's really understanding that we may look at seeking services as black and white, but it's not as black and white as that. And therefore, when you design your services, you have to bear in mind these other issues where you might be having to consider going to the community as opposed to the community coming to you, kind of scenario. So understanding this, there's a real lack of understanding of disease progress, and again that presents in different stereotypes in terms of understanding of illnesses. There is that also plays a huge factor on treatment decisions, and whether I will seek medical help in a clinic, or whether I will try traditional or herbal treatments, or whether I will try alternative medications. So all of this really plays a role in this influences the factors. So if we dig a bit deeper into the health-seeking behaviors, it's looking at what symptoms are serious, what are not serious, what do you perceive as serious, what do you not perceive as serious. I think it becomes even more complicated where particular illnesses like HIV have no symptoms in some cases, and that gives a perception that there is no need for emergency, no need to seek help. Then you look at other illnesses like TB, where again, someone will present when they are really, really ill and can no longer physically function. But initially they had the symptoms, but did not take them seriously. They thought it's just a cold. I can still continue to function, so I'm not going to engage in healthcare. It also could be the healthcare system. It's not free. I need insurance. I don't have insurance. So if I can still function, then I'll wait. The symptoms are not serious. I'll wait. Hopefully they'll go away. And then they become serious and they're in a point of crisis. The things around how long they've had the symptoms for, or how long they last. Is anyone else, for example, are there outbreaks in communities? If we're looking at camps or communities where we know that particular people of different ethnicities converge or settle? Are there outbreaks, similar outbreaks? Does someone have similar symptoms like I do? And that will all factor in whether they will seek help or not, or whether there is stigma or shame associated with the symptoms, and that will affect whether they will seek help or not. Then in terms of perceived illness, some people believe, I said, it's a cause of punishment for something they have or have not done, or their spiritual outside forces, supernatural forces that are playing a part in what they have. And you'll be very surprised for so many illnesses, whether it's HIV, whether it's TB, whether it's sexually transmitted infections, there are so many communities that associate that with punishment or supernatural activity. So it's also looking at the patient's perception of messaging and how that is different from you as a healthcare provider. Understanding that you may put out a messaging, but the understanding from the patient's perspective is totally different. And this is because of language, dialects. Again, in some of our messaging, it is the images we use. In some health settings, and I'll speak for the UK, we've seen that messaging around sexual health is very sexualized, and yet in certain communities there's a disconnect between sexuality or sex and what they actually do. So the tone of your language is very important in the buy-in for somebody to effectively engage with you. There's a lot around stigma and fear. Fear may be what community will think. Fear may be they're associated with their status. Will they be deported? Will they go into prison? Will they be criminalized? There's all those other factors that play a role in terms of the decision making and engagement. And then also social networks also really play a huge role. And we find with communities that converge in particular areas, then that becomes the peer dynamics that plays a role, and that affects whether they engage or they don't engage. But it also plays a huge role in transmission of illnesses and risk as well. So looking at treatment decisions, what is necessary for healing, how whether, what options do they take? What options have they got? Others will go for contemporary medicine and combine it with herbal medicine. It's all those things that culture plays a role. And then in terms of the cost-benefit analysis, where we're looking, for example, now in Europe, where healthcare is not free, and you don't have insurance, or you have to pay additional costs towards your treatment. Is what I am suffering worth the cost I have to pay or not? Or do I actually have the money to take care of my healthcare, and maybe I will just wait for it to go away or heal by itself? So there are all those factors that play a role. Then lifestyle as well plays a role. You are talking about providing pre-exposure prophylaxis to clients, but you only open the clinic between 8 and maybe 8 and the work hours in a day, 8 to 5, but maybe the person trying to access the services also works between that time, or maybe they have a nightlife and during the day they are sleeping, or they are sex workers and they operate in the evenings, so the time that they would actually access your services are also in the evening. So it's understanding those lifestyle factors as well. And then it's also around the interaction, you as a healthcare worker or as a provider of a service, and how you interact, how you earn that building of trust between you and the community you're working with. That is also very important in determining whether they will come for treatment or not come for treatment. We have had scenarios here in the UK where somebody goes to a GP, a general practitioner, and they need treatment, let's say for a diabetic diagnosis, but they also are living with HIV, and then the doctor is really honing in on how come you have HIV? I cannot believe that you have HIV. Where did you get it from? That puts this person off, and they will not go back to the GP for their diabetic treatment. So it's those kind of non-judgmental service that you provide, as opposed to the biases that we come with. So I thought I will also touch on what skills do we need in order to really effectively engage with our communities. So it's understanding the cohort of patients or populations that you're working with. And this is something Leila mentioned earlier. So it's really understanding, putting yourself in their feet, taking the time to understand their beliefs, their anxieties, their history, the trauma that may have been involved in that, accepting the acceptable social behaviors or not if they are not there, and understanding what social behaviors they have compared to what you may know or may not know. cultural beliefs, faith beliefs, also I'll add that there. It's conveying respect to this person and mutual respect and understanding what that means to a person. And then it's helpful if you can work with interpreters as well, so that you are really speaking in a language that they understand. There's a saying, a quote from Nelson Mandela I use a lot, where it says, he said that if you speak to somebody in a language they understand, if you speak to somebody in a language they understand, it goes to their head, but you speak to somebody in their language, it goes to their heart. So if you have an interpreter who is speaking to them in their language, there is a tonation and a choice of words that will resonate better than if you're trying to speak to them in English and there's misconception of words, misunderstanding or not understanding words, and that will have an impact on how the decision around treatment or engaging in your services, or what it is they tell you in terms of their medical history or not. We've talked a lot about the cultural sensitivity. So those are the kind of skills you need to, or what you need to put in mind as you try and develop your services, as you engage with the different populations, to make sure you get the most impact out of that. Are there any questions at this point before I go ahead? Okay. So this is again me talking at you for a little bit, but we will become interactive again in a short while. So knowing the cultural characteristics of your patient population, if we just dive a little bit deeper into that, what cultures are predominantly representing your program, understanding the cohort you're working with, what are their values, what are their beliefs, what are the tradition concerns of this group that you are working with, who are the gatekeepers within that group, because in some communities they have hierarchies. In those communities, some communities, women don't have a say even with regard to their health. It is their husbands who have a say. So understanding that dynamics, and how do you actually engage with this woman if she's speaking through her husband? How do you engage with community leaders? How do you engage with faith leaders? It's who can influence and have an impact to enable your work as well. And then the group's perception of health and well-being, and we know that well-being is relative and it depends on someone's perception. So it's really understanding that group's perception around health, around illness as well. Then understanding what are social behaviors. In some cultures, certain things may be acceptable, while in certain cultures they are unacceptable. A simple gesture like shaking a patient's or shaking a community member's hand in some communities is acceptable. In some communities, it's not acceptable. Some communities, looking at eye contact is acceptable. In certain communities, it's not acceptable. So it's really trying to understand who you're working with, and in certain communities, there is a bit of build up to engagement. So if you're a physician engaging with a patient, asking direct questions around, also, you have this medical condition, you have these symptoms, tell me about them. For them is abrupt. Asking them how they are, how the family is, and building that rapport first buys them into building the trust with you. So it's just understanding those differences and how effective they can actually make a difference in the engagement of the community. Then if we look at examples of health beliefs, again, we touched a little bit about this, but I thought on this, but I thought I'll just stress a bit more in terms of causes and myths around why people have diseases, or thinking that it could just be stress or it could be punishment. There's things that I found interesting to just add here, and we can add more. Feel free to share with the group. Eating protein will affect or interact with X-rays. Everyone has a dominant disease in their body. Whether or not it develops depends on how well they take care of themselves. So you will have all these theories, but understanding them from cultural beliefs is very key, and understanding in your own community. So at this point, I'll ask, does anyone else know of any cultural health beliefs that are out there that you've encountered or that you believe in? Let's also not be judgmental. Anybody want to share anything you've had? Yes, Pavi?
Yes.
Yeah.
Okay, Poppy, go ahead.
Okay. No, what I want to say is that it's very important culture, we all know, but sometimes it can affect our work. It does not matter how much you are trying to be culturally sensitive with the meeting the contact group. Some of them, it can just it can bring some kind of frustration. So we put culture is a big envelope where we put a lot of things that are not even a culture. So anytime they want to find a reason not to do anything, it's not in my culture, or it's not accepted in my culture. So that can be a frustration with us providing support or services. When, for instance, someone saying being a priest or one of these pastors and not taking medication, saying that he does not believe in HIV, though he's living with HIV, and the wife is taking the medication, but he's going around bullying people that he does not believe in HIV because God is taking care of that. So it's not, I don't see that as a culture. I just want to give that as an example. So challenging just to put everything on culture.
Well, that's culture in the aspect of the faith and what that role that faith plays in that, and it's very common for people to not accept the diagnosis or not even believe that the treatment works, or others to have more faith in faith leaders than the actual medication. So that's very, very common, and it's around building that trust with them. Slowly, it takes a long time, but building that trust, because I'll give you an example of a patient who stopped taking medication this was a patient living with HIV, and went to a church, and in the church was told by the pastor, they've been cured, they don't need to take medication. So they stopped taking medication. And what eventually happened is they presented in hospital with throat cancer. And that is when they started re-engaging with the healthcare system, started taking medication, and now becoming an advocate for other people that, don't listen to people in churches. You should take the medication because it helps, because I stopped and I ended up falling ill. So it's not a clear-cut, easy answer, I would say, but yes, it is. It's something we know happens, and yes, they will use culture always or anything, faith or culture, but it's building that repertoire with them. Thomas?
So what I wanted to add to this maybe is that for me, this also has got a lot to do with unnecessary stigma and discrimination within healthcare. So if I look a little bit beyond our own typical disease areas like HIV and STIs and TB, viral hepatitis, we know how much stigma and discrimination there is, for example, in obesity, like doesn't matter what causes your obesity, you're usually accused of being lazy or not eating well. A similar example would be diabetes, which is just called a lifestyle disease, which does not necessarily has got anything to do with your lifestyle. In many cases, it doesn't. Or maybe you cannot change your lifestyle at all. It's just something that's a given because your social circumstances maybe don't allow you to eat better because you live in a food desert, or you don't have money to eat anything else than what's available. Or lung cancer. Doesn't matter whether you smoke or not. If you get a diagnosis of lung cancer, then the first assumption of people is that it's your fault because you smoked, and they don't even ask whether you ever smoked or not. So this is, I think, it is to me a much broader aspect, or concept, which also, by the way, opens an avenue to all of us to work with other activists and advocates in other disease areas, because they have similar challenges and they face similar problems. So it's good and bad, but it just shows how deep the roots of these challenges are, and that it's not necessarily exceptional to our field or fields, but it's something that's persistently present in healthcare, unfortunately.
No, thank you for that. And I think there's also the acknowledgement that the people we are working with, the patients that we may be seeing will present with multiple conditions. So the assumption cannot be that they will only be living with HIV, or they'll be living with a viral infection, but they may then have diabetes, they may then have the cancer, they may be a sickle cell patient. So it's really important what you've said around working together with these other organizations, because the barriers are still the same, the patient is still the same, and all these other compounding issues that we find around the misconceptions are still also the same. So thank you so much for sharing that. Anybody else? Okay, so let's go to the next slide. And this I just put, and I know that you're already, in the field, you've experienced this, but I just thought we cover some of this in terms of how we convey respect and how we buy in. The buy-in we have, building the repertoire and trust with the communities or the patients you're seeing, being able to be sensitive as you talk to them in terms of how you ask questions. Do you express empathy in terms of how you're doing that, even with frustrations you may have, like the voice is mentioning around those who will blame it on culture, but is there empathy and patience, trying to work with these patients to bring them along that journey, to understand that whatever service you're providing is for their benefit? Yes, go on, Prabhu.
But the key issue with working with intersectionality, I'm not going to extend too much on this, is when, especially in the migrant group, people use culture not to accept each and every one in the groups. And we cannot keep on having activities, because we work with awareness, we go to schools and all that. When you listen to what they are saying, for example, about LGBTQ issues, how much time or patience do I need to have to build this rapport and trust? How much am I going to spend on that each individual trying to disturb in the class? Sometimes I just give up and I throw them out, but because I cannot believe that someone searching for human right will sit and be abusing someone else in front of people because of their culture. In their culture, this is not accepted. These are challenges we need to be open and talk about. We cannot just be accepting anything because of culture.
Thank you. And I will throw this back to the group. And what advice does someone offer for Kobe in this situation? Any suggestions from, or has anybody else encountered this, and how have you gone about it?
No, what I want to add is that there is no answer unless you encounter that you are in the group, because we work in the field. Not everyone is working in the field, but these are challenges we meet. It's not that luckily that I have many years experience working with that, but I just want to bring it up so that we don't beat around the bush, or we just don't say, oh, this is culturally sensitive, because culture does not go above human rights. For me, that is the limit. That is the, I can be patient, but culture and human right is not, I don't want to negotiate there. I cannot negotiate there. I'm just bringing it up. There is no answer, but that we should, even as educator, as a trainer, those are issues that we need to be bringing up as cases and see how do you deal with that when you meet that. It's very important.
No, thank you. And I totally agree with you. And I think when I say these are real challenges, I am also aware that those tensions are there in particular communities. And this is why I wanted anyone else to share. But I think, yes, we cannot be blind to the fact that it is time consuming without the resources that you may not even have to spend that much time. But I will be also optimistic that gradually over time, these perceptions will change within the communities, or working with the leaders within, or people who gatekeep those kind of communities. I know you've spoken about schools, but I know that the children will have these notions come from parents and homes, and it's again sensitizing all of that. But I hear you, and we can't work in isolation. But I'm looking at it from the aspect of getting, so these children you're trying to talk to will be your patients if at all they don't come on board. Have I got that wrong?
No, sorry. We go to adult. It's adult schools, Swedish schools, language school for adult migrants.
Okay.
No, we don't work with children.
Okay. I misunderstood that, but thank you for that clarification. But even still, it is that it will take time, but it still involves building the rapport and trust with those adults over time to generally then get them to understand your perception of the human rights, and how it is also their right to get health, just as it is their right for somebody else's sexuality. And then if we look at observing, when you're speaking to observing the verbal and non-verbal clues when you're speaking to patients, and this can be patients who've experienced trauma, patients who are experiencing abuse, or other patients who may just have cultural influences in terms of how they verbalize or non-verbalize information, and just being really aware about that. I'll give you an example of a young lady who came from Botswana to the UK, had to run away because she had 5 children, had left a 2-month-old baby behind, but 2 of her 5 children were boys, and they were taken away from her because they wanted them to perform certain cultural rituals and stuff. So, and she ran away. But as she was accessing services, when they would try and ask her, she's not engaging in the service. She's not adhering to medication. And when they're trying to ask her to get to know a little bit more about her, the questions she felt were very insensitive, and yet she had a lot of trauma and psychological effects that she was going through. She always just burst out crying. And the physician in front of her thought maybe she's on drugs or she has a problem and with drug and alcohol. That's what they put it to. But on one particular occasion, it so happened that a person, a nurse in the clinic was with the physician, and the nurse was Black. And this time they decided, let's see this patient together. And when they saw the patient together, this patient was now able to open up about leaving her child behind, take her boys being taken off to perform certain rituals. And the reason she felt able to speak was she felt that this Black nurse would understand the positions, but she felt that the white physician may not understand when she says, my children have been taken away, my boys have been taken to do certain rituals. She felt there was no way there would be that kind of understanding. And truly, even the physician had misunderstood, because then they realized the trauma and a lot of issues that this lady was facing that were affecting her adherence to medication and her well-being and state of mind were down to that trauma she had experienced, not drug or alcohol or just not wanting to engage. So it's those kind of things. So again, we're looking at respect and acknowledging the non-traditional issues that may be affecting this person, whether they are living in an extended family, and in some extended families, then your business is everybody's business. So they are very mindful of what they will say or will not say, whether they're homeless or living in a shelter. What does that mean? In certain cases, we found, again, I'll give you examples in the UK where asylum seekers are all housed in hotels and they are sharing rooms, and one person is HIV positive, they have medication, they are worried that the person in the room will see their medication and therefore know their status, so they don't take medication because they don't want to be ostracized in that small community that they face. So it's really understanding those challenges and how they present. It's the being aware of the role stigma plays in terms of diagnosis, in terms of treatment, and even some cases in terms of prevention. Someone being seen with condoms in a community setting, if they are of a particular faith, they may not want them to be seen with that, or if there is they have transactional sex, then they may not want to be seen with the condoms. So it's really understanding all those dynamics that play. And we all know about immigration and what that entitles you to and what it doesn't entitle you to, and really understanding all those intersectionalities when you're speaking and dealing with the community members. Then if we look at working with interpreters, and this, like we said earlier, was crucial, and it can sometimes be a very good thing, and in some other cases it can be a very bad thing, because in some communities they even mistrust the interpreters. In other communities, they feel the interpreter is so close to home because the communities they come from are very closed and very small, so names are very identifiable to the family tree. So if you tell them, I'm bringing you an interpreter from their country, they worry that information is still going to go back to their origin or members of their community. So it's really understanding when you choose to use interpreters, the reassurance that they're professional, that they are governed by confidentiality and code of conduct, and really giving that confidence of the service that you're going to provide. It's also around addressing the patient directly and not in third person. It's making them understand that communication is to help them. You're not bringing in a third person and you're talking about the patient or the community member as if the third person is more important than the community member. It's the third person has been brought in to facilitate. And if it's over the phone, again, just being mindful of the role that you're using an interpreter for and the dynamics in the room as well. making sure that the interpreter is also using appropriate language. We've had cases of interpreters who are not really interpreters. So it's just vetting and making sure, because all of that plays a huge role in trust within the community. This person's experience will be shared. If it's a good experience, it will be shared within that community. If it's a bad experience, it will also be shared. So being really mindful of that. And with all cases, it's around avoiding jargon and phrases and just being clear. You don't use very big words. Don't make we have tendency in medical to use medical language, but medical language, you have to be mindful, may not be interpretable in local dialects. So someone may have an STI and that word cannot be translated in the line. So we have to really be mindful in terms of how you use phrases and words that we use. Then looking at cultural sensitivity, again, we are looking at what materials do you have around? What materials are you using to communicate your messaging? If it's around campaigns, if it's around sensitizing the community, how are you representing this information? How representative is it? Are people seeing themselves in this information? Looking at again, looking at ethnicity, looking at racial profiling, all these factors and in terms really play a huge role in terms of how that message is conceived or received within the community. Do you provide translation of materials in the languages of the communities you're predominantly working with? And another caution to all of this is sometimes we found certain people in certain situations, they will provide the translation. But again, not everybody who speaks a language can read that language. So it's really being aware that for some people, they may not speak the native language. For example, they may not speak French, and then you're translating into a dialects where they come from, but they don't necessarily read that language. They may not be literate, but they can speak it. So it's also being mindful about those kind of things. And then also for non-able-bodied, whether they have hearing impairment, visual impairment, mobility issues, it's also bearing all of those things in mind when you're designing and providing a service. Then also looking at how you make different ethnicities, genders, age, all feel comfortable in the setting, all feel that the service you're providing is a service for them. Looking at your frontline staff, looking at non-clinical staff, are they trained around culture competence? Are they trained around how they engage because they're front-facing? A lot of criticism has been had where, yes, you'll have doctors and physicians who are very aware about the culture, but the frontline staff, the receptionists, are very judgmental when they get to know someone's illness, or they ask more information than they need, or even simple things like the setting area. Is it an area where someone comes and as they speak to the receptionist, everybody in the waiting room knows their business? That is a hindrance for some people. They would rather, I'm not going to go there. Or how big is the waiting room? For some people, they feel their community is so small. So by me going to that clinic, everyone's going to see me in the clinic. What is going to go back that I went to the sexual health clinic? So we really have to be aware about this in how we design our services. To encourage engagement. So it's kind of remembering that culture is not defined exclusively by ethnicity, but rather by shared systems, values, beliefs, history, learned patterns of behaviors. Also that these system values, sorry, I'm trying to move. These systems of values, beliefs, and behaviors might also be influenced by other variables such as gender, language, disability, sexuality, and age. All of these play a huge role in terms, and we have to really be mindful about that. So I have spoken for a very long time now. I'm going to again get you back into your groups. You'll be in the same groups. And for this exercise, we do have 10 minutes. So I'll give you 5 minutes to discuss, and maybe I can give you 6 minutes just to get you to discuss creating culture competence in your healthcare setting. So looking at what you do, where you work, what can you do, how can you, given all we've discussed, maybe what are you doing already, or what do you think you'd like to do? What would you like to see on reflection? So Hala, if you can just open up the rooms
sure.
again. I hope you had at least some time to have some meaningful discussion. So if we start with Cele 1, because you are a bigger group, who did you designate as feedback, or who would like to share? Doesn't have to be one person. Yes, go ahead.
I wrote some stuff down for what we discussed. The first point was to recruit people from specific communities, the specific communities we serve, either as community health workers or peers, for either support or information. And we had the example of in Sweden, they hired a Muslim woman so they could reach the specific populations that had distrust in Christians going there and providing services, etc. And also providing additional training and education to non-peer employees that have to tackle issues of different cultures, etc. And that's pretty much what we were able to discuss in the time we had.
Thank you. I'll go to Cele 2.
I'm happy to report back. We had indeed a short discussion where we came to two conclusions. One is a point made by Uwe that whenever someone comes to Germany and wants to settle here or integrate themselves here, whatever that means, then this integration really means that we try to accommodate them in the system, and they have to adapt to that system without respect for their own culture. So it's rather, we expect migrants who come to the country to follow German culture and to fit the mold, rather than respecting their own cultural needs and specificities. And the other comment we made is that we do not always acknowledge that people arriving in the country may have more complex health needs than just an HIV test or STI testing, but they may have more complex challenges which are not necessarily acknowledged or handled. That's what we discussed, and then also that it's very challenging in the UK at this point. It's not just Germany, but also the UK is has become a very challenging environment.
No, thank you. And I think I have enjoyed listening to those reflections, and it's very good for me to hear, the example of employing a Muslim woman to engage with particular communities. It's very important for someone to see themselves in the service they're trying to engage. But sometimes that's not always possible. So the bare minimum should be some understanding of the community that you're trying to serve, and try and educate yourself to understand that community, so that you will be able to serve them the way you would like to serve them, the way they expect to be served. That's at least the bare minimum. We also have to acknowledge in certain settings we can't provide all these things, but at least we can have the competency to understand that the cultural differences, the beliefs, where they're coming from. I really like Leila's bit of put yourself in their shoes. It will help you see it from that perspective, and how you then provide a service. I know that politically there's a lot of hostility around migrants, and the expectation that you've come into a different country, therefore you follow our rules, you follow our culture, you follow our beliefs, citing France, for example. But we also have to acknowledge the effect that has in terms of engaging in services, in terms of accessing of services, in terms of retention in care. And that's the wider social determinants that really affect all of this, and bring the inequalities that we in the UK are seeing now. When it comes to statistics, the people left behind are the migrants. When it comes to healthcare, they're the migrants. When it comes to late diagnosis, it's the migrants. When it comes to presentation of a degree of seriousness of illness, it's the migrants. And the biggest impact, again, for the UK setting, is the cost to the NHS. Because for us, yes, healthcare is free, but it is a cost to the NHS. So the NHS has had to learn that actually investing in communities and those services and investing in competence, in the end, costs us less. So it's better that we understand the communities we are trying to serve, so that we can alleviate these inequalities. So that's just I thought we share, and I thank you for that. I've got a case study that I'm going to share on the screen, and I'll give you 2 minutes to read it, and then I'll just let you offer, whoever, just offer what you see. And this is a real life scenario that happened, but just offer your thoughts of what you see and how you would support this person. Okay. Can anyone offer to give us a bit of what do you see are the issues? And I think this sums up a lot of what we've covered today. But what do you offer as a way of engaging this person? Yes, Farhan?
Of course, I don't have the solution, but just a reflection on what was mentioned before earlier a lot of times, that this situation is not one issue, but it's a complex one. And I think one of the problems is that the services she's engaging with, trying to sort out homelessness or HIV or another problem, but we should look at it as a complex issue and try to find solutions that brings her out of this complex situation she's in.
No, thank you. And I think that talks about the partnerships that we talked about earlier, to be able to work with partners, because the communities we come with issues that are intersecting, and how we cannot work in silo. So we have to work in partnership. So yeah, thank you. That's good. Any other observations? Suggestions? You see how complex this case is, and it was through more interventions when they then revealed the debt they had and the effect on the families. That was not brought up in the beginning. And in the beginning, it felt like she was just being a disruptive person who doesn't want to take up accommodation, who is, again, you would use faith and as an effect, but there were deeper things around looking at dying out of hunger as a better solution to suicide. So it's really understanding this and how culture and beliefs all play in how somebody presents, and then in turn how you actually support this person.
I think it's also important. I mean, one of the things in this complex case is also being able to give her adequate legal advice of these things of debts. I don't know how it works. Of course, I'm not a specialist in these things, but I guess these people she thinks she has debts with are, of course, how do you say, they're not, traffickers, and they cannot be officially claiming that the debts that she has, but I know that threaten the families, they do things. So she needs really specific legal support in order to feel at least free from this threat, and and be able to take better care of her health, because one of these complex things is, and counseling these people is go by priorities, which is the top one to go then and solve little by little all the ones. Usually you cannot take care of everything at the same time, but there are probably priorities to be identified to follow her through the path and maybe allow her to go back home, and with proper care, though not the bath in the holy pool that would not help her to heal from HIV, but to give her proper counseling and care step by step.
No, thank you. And in the interest of time, I will move on because we have 5 minutes left and yet you have an evaluation. So I had a small video. Since the slides will be shown, you will watch the video. But the reason I shared this video, it's a video we created talking about PrEP, but I want you to look at how we tailored it to a particular community in terms of language, in terms of the visionary, in terms of the words, the messaging. So it just shows you how you can adapt your message to a community. And then I want us to go back to key takeaways, and we've talked about language and what that plays and the role of translators, and making sure that you understand, dialects and translation of words may not be existent in particular language. Also being conscious of biases that we bring to the table and how those influence how we see things, and being open to change or to understand or to put yourself in someone else's feet. Also to understand that sometimes there is not a good or bad way of people are just different, and that's just what it is. Then also the environment and how that shapes us, the environment you grow up in can have an impact on your experiences and engagement. For some people, historical trauma and harm that they may have experienced plays a huge factor in terms of access to services or in terms of how they engage in services in the present day. So being very conscious about their reality. And then just if we briefly revisit the objectives, this we started by saying would be defining culture and linguistic factors that shape our culture, identity, stereotypes, bias, and cultural awareness. We looked at describing our culture identity and evaluating how these shape our own biases, developing a personal awareness of these topics and how we can relate to our roles in a healthcare as a healthcare provider. And lastly, the role of culture competence in reducing health disparities for migrant communities. And I hope that we have actually covered that. So I can take, if there are any questions, but if not, those are my details and we can move on to the evaluation. So if there are any questions or any suggestions or comments, please feel free. Okay, so I can pass on to Hola and Chris, but thank you so much for being good colleagues on the screen with me, and I hope that this will help the work you're doing. And if you need any further information, support, my contacts will be shared as well, so you can reach out. Thank you.
Thank you. Thank you very much.
Thank you, Judy.